Ted, we've seen a lot of discussion around site-neutral payments and trying to reform this disparity that existed between what oncologists were being paid in the hospital and what they're being paid in the community setting. Can you talk a little bit about what I mean by site-neutral payments? Why did these disparities exist in the first place, and what happened recently to do something about this?
Right. Well, they're actually not site-neutral payments. That's what we want to create.
We want to make them site-neutral.
The disparity in terms of if you look in the hospital setting, I'm talking about the hospital outpatient setting, and you go into the hospital outpatient, and for example, you get chemotherapy, and there's the first hour payment for the first hour of chemotherapy by Medicare. It's extremely higher than the payment that you get when you go into an oncologist's office. And let me tell you what's interesting about this. As more hospitals purchase oncology practices, I have seen patients that from one cycle to the next, they go into their oncology practice, see their doctor, get the chemotherapy administered, walk out of the building, and then the next cycle they go into the same building, they're seeing the same physician, they're being administered chemotherapy by the same nurse, and they get their bill, and it's extraordinarily higher because in between those cycles, and this happens all the time, that practice has been acquired by the hospital. And the hospital is billing under, first of all, a higher payment for that first hour of chemotherapy, and then they're adding on a payment for a facility fee under Medicare. So, you know, this is one of those things of, Scott, I couldn't tell you how it's evolved as much as it's evolved, especially because the hospitals say they need higher prices because they have to subsidize their emergency room and they have JCO accreditation issues. But the problem is that there is this disparity and it's costing Medicare a lot of money. So what was interesting is, and very interesting, and it caught a lot of people by surprise, except us, is that in the Balanced Budget Act that the president signed back in November 2nd, what happens is any hospital that's in the process of acquiring a physician practice or acquires a physician practice going forward or has an off-campus facility that's defined as being 250 yards from the main building, come 2017, instead of billing under that hospital fee schedule, which is a higher payment, they will have to bill under the Medicare physician fee schedule, which is a lower payment. So even though we would like to see payments and we think payments should increase on the physician side, what this has done is it's the first time that's created actual payment parity. Now, sites that were already acquired are grandfathered in. We'd like to see that change, but right now, at least going forward, we will see as CMS basically digests this and figures out how they're going to administer it, in 2017, there will be site payment parity on Medicare going forward. It's a big step.
And do you think that's going to intensify the acquisitions of private practices up until December 31st of 2016?
No, here's the problem. Here's the problem, John, and this is why some are upset about it. When the president signed, the second he signed that law into effect, that's of that moment. So literally, if an hour later there was a practice that was acquired and then put on the hospital cost report, they will be billing 2017 under the physician fee schedule. Okay. So if you didn't do that, in fact, a lot of people have said, why wasn't there a grace period? You would see this huge influx of acquisition activity happening. And at least Congress did the right thing. For once lately, they did the right thing in terms of actually saying, no, it's when the president signs the law.
Of course, there was a deluge of practices getting acquired the day before it signed. I'm just kidding. So the practical effect is going to be that you're probably going to see the number of practices that get acquired by the hospitals go down somewhat, because in some cases they were playing this arbitrage, if you will. Although there's other things like 340B, other reasons why hospitals might want to get practices.
I think what this does is, if you look at this as being sort of a hemorrhage of practices. So if you look in the oncology space over the last 8 years, we've basically seen close to 500 practices, multiple sites acquired by hospitals. And it's a big problem because we see consolidation. We also see over 300 clinic sites that have been closed. So, but the problem is, in this hemorrhage, this is a nice little Band-Aid. Don't get me wrong, and there's a little stitch in there, one or two, but the biggest driver of acquisitions now is 340B, because if you think about it, the economics are really simple here. An average oncologist can account for about $4 million worth of drug a year, depending on what he or she treats, what types of cancers, and therefore what drugs they use. So if you look at 340B discounts, which are between 30 to 50%, and on the brand side average out around 40% or so, but can go up to 50%, you're looking at $1.2 million to $2 million of huge profit right to the bottom line. And you just talked about arbitrage. Scott, I mean, this is the biggest form of arbitrage there is. So the biggest driver in consolidation is still on that level. And in fact, a report just came out from the Berkeley Research Group, and this is very interesting, that almost 25% of all Medicare Part B is 340B. Almost 25%. If you look at just the outpatient setting of hospitals, over 60% of the oncology drugs are 340B discounted. So it's something that's unsustainable and has a lot of unintended consequences.